അതെ. ഓക്കെ, സ്റ്റാർട്ട് ചെയ്യട്ടെ. Okay. So good evening all. Myself, Dr. Arunas, will be discussing a question which is almost sure for your exam. Before that, I would like to tell you a few things regarding the question paper pattern and what all the things you should be concentrating on to secure more marks from each question. So as per the schedule given by the KUHAS, you have your examination on 12th March, which is general surgery paper 1. In paper 1, you have 2 essays of 15 marks each. That means you have 30% marks in that question in the form of essay. In paper 2, you have 2 essays of 10 marks each out of 70 marks. So that is approximately 28.5%. So when you get a question, you read that question carefully. For you, I'll be discussing about a renal cell carcinoma. So the question has been put up here. I'll read through that. A 29-year-old gentleman presented with hematuria, which is on and off, which is associated with left-sided loin pain, no previous urinary complaints. He is a painter by profession and a chronic smoker. On examination, there is no pallor. Per abdomen, a mass is felt in the left lumbar region, which is moving with respiration, and it is ballotable. He has a irreducible left-sided varicose vein. Sub-question is, what is the most probable diagnosis? Common and atypical clinical presentation, relevant investigations and treatment options, and why is that varicose vein irreducible? So, once you have read the question, you try to understand the scenario, look at the sub-question and plan your answers accordingly. So, you have to write it legibly and to the point. That is one important thing. You have to draw diagrams as and when required. And then if you follow a pattern for this, that would be ideal. So what I am trying to deliver for the next 15 to 20 minutes is a framework for this question, which is based upon Bailey and Love 28th edition. And I am repeating, this is just a framework or in a nutshell presentation. You have to extrapolate it. Okay. So we'll go to the next slide. So most probable diagnosis would be RCC. So renal cell carcinoma, which is a most common solid neoplasm of the kidney, accounting around 90% of renal tumors and 5% of all adult male malignancies and 3% of women malignancy. So it can be familial or sporadic. Familial includes association with von Hippel-Lindau, which is a combination of a clear cell RCC, pheochromocytoma, retinal angioma, hemangioblastoma of the brain, brainstem, cerebellum, and spinal cord. So, in the question, it has been given as the patient is a cigarette smoker, he is a paid worker. So, all these things are risk factors. Apart from that, obesity, hypertension, and acquired renal cystic disease and chronic kidney disease also is a risk factor. So, what are the classical presentations? And the question here is classical and atypical presentation. So, classical presentation would be, which is a palpable mass hematuria and a flank pain. In an advanced disease, can present with fever, malaise, or weight loss, and bilateral lower limb edema, along with the varicocele. In this patient, there is a irreducible varicocele. 30% of presentation is via paraneoplastic syndrome, which is high ESR, hypertension, anemia, and hypercalcemia. And 25% present as a metastatic disease, where there can be cannonball metastasis in the lung or can present as pathological fractures. So that answers the other part. So coming to the pathology, clear cell carcinoma, which is usually a solitary malignancy, a tumor arising from the proximal renal tubular epithelium, which is a slow growing tumor and it is bulging out of the renal contour. You can have familial RCC, which is the second most common tumor, which may be bilateral and may be having multiple tumors. You will have papillary type of renal cell carcinoma, which is the second most common, which may be sporadic or familial. So type 1 is having a better prognosis than the type 2. Next comes the chromophobe RCC, which is sporadic or familial. It is having a very good prognosis. Then collecting duct carcinoma is a rare tumor, approximately 1 to 2%, which is very aggressive, arising from the renal medulla, so that the tumor is centrally located. And renal medullary carcinoma is the rarest of the lot, which is less than 0.5%, very aggressive than the collecting duct carcinoma, usually seen in young individuals and with a sickle cell trait. It is also a centrally located tumor, and sarcomatoid variety has got a very poor prognosis. So how does this spread? This spreads with direct invasion to the perinephric tissue through the capsule, or it can encroach into the renal vein as a thrombus, and vein wall invasion carries a very poor prognosis. So the question regarding the investigation, the must-do investigation apart from the routine, here you go for a CBC plus ESR, serum creatinine, LFT, LDH, corrected serum calcium, the coagulation markers, urine analysis, alkaline phosphatase. So a very high alkaline phosphatase can lead us to the probability of a skeletal mets. In that situation, you may be forced to go for a bone scan. So what are the radiological investigation? Usually an ultrasound can diagnose a renal tumor, but the investigation of choice would be a triple phase CT, where the renal cell carcinoma typically shows a contrast enhancement after the contrast administration. A change of more than 15 Hounsfield unit is considered to be significant. So what are the additional factors which are there in the CT? When after you have taken the CT, you can get a fair assessment about the size of the tumor, the extent of the tumor, whether there is the venous involvement of or not, regional node involvement, status of the adrenal gland, whether there are any intra-abdominal mets, and moreover the functioning of the contralateral kidney. MRI also can be used, which is superior to the CT, to detect the tumor infiltration into the vein wall and to assess the level of the thrombus. So a chest radiograph also can be taken in all cases, and a bone scan, as I told, uh, in case of an elevated alkaline phosphatase or bone pain or in the presence of hypercalcemia. So involvement of the lymph node, renal sinus, vein wall, all these things are indicative of a poor prognosis than the presence of a tumor thrombus in the renal vein. So after all this investigation, you go for staging, which is TNM. So stage 1 means a tumor is less than 7 centimeter in the largest dimension, confined to the kidney. Stage 2, tumor greater than 7 centimeter in the largest dimension, confined to the kidney. Stage 3 is tumor is encroaching into major veins or adrenals with an intact Gerota's fascia, or there is regional lymph node involved. And lastly, the stage 4 tumor is beyond the Gerota's fascia. This can be depicted easily by a diagram which is given in your textbook. Okay, it will hardly take 1 minute for finishing that. Then comes to the management options. Management options are nephron sparing surgery, or it can be a radical nephrectomy. So nephron sparing surgery, it is done for small tumors less than 4 centimeter. Usually a partial nephrectomy is done for tumors for 4 to 7 centimeters. So that will be less than stage 1. And this is also attempted in tumors where the patient is having only one kidney, or the patient is having a pre-existing renal dysfunction. Alternative techniques for small tumors where the patient is unfit for a major surgery is you can put the patient on surveillance, or you can ablate the patient who is having a higher risk. So coming to radical nephrectomy, the removal of the entire kidney is done with the Gerota's fascia, ipsilateral adrenal gland, and regional lymphadenectomy. These surgeries can be either done open, laparoscopic, or by robotic means. So lymphadenectomy is done for high-risk individual with large primary tumors and nodal involvement. So what about the management of a thrombus, especially in the IVC? Usually IVC thrombus is found in 5 to 10% of cases, and thrombus is extending into a retrohepatic or suprahepatic IVC. In that situation, the surgeon has to mobilize the fully mobilize the liver and access that. Or if the thrombus is extending beyond that into the right atrium, then the patient has to be put on cardiopulmonary bypass and circulatory arrest, thoracic surgeon help, all those things are needed. The fourth situation is metastatic RCC, which is 30% of cases present like that. You assess the performance status, you assess the time from diagnosis to a therapy, look for the hemoglobin level, calcium levels, platelet and neutrophil count is used for risk stratification. So non-operative management like tyrosine kinase inhibitors, which are sunitinib or pazopanib, may be used. RCC as such is an immunogenic tumor, so you can go for interleukins or interferon treatment or targeted therapy like immune checkpoint inhibitors and anti-program death 1 or program death ligand 1 inhibitors. Any one of these can be used. Then a word about cytoreductive nephrectomy, which are used in intermediate risk patients. And here palliative nephrectomy is done in intractable hematuria or pain or a symptomatic paraneoplastic syndrome. Other option in patients who are unfit for surgery are angioembolization in case of intractable hematuria. So this is in short the salient points regarding uh, renal cell carcinoma. So I would suggest that you go about with the framework of a definition or then comes the etiology, then go for the pathology, then clinical features, investigation and diagnosis, staging of the disease, prognostic factors, and then management options. So that will complete the full topic of renal cell carcinoma. So if it is asked straight as a question like uh, the risk factors, clinical features, investigation and management of renal cell carcinoma, you can go like that. Otherwise, if it is structured essay, then choose the appropriate question and then write the relevant points and then finish that off. Okay, thank you. Hello, thank you. Since it has been quite a long time, we'll plan the other two in another session. Okay. Okay. Shall I leave this? Okay. Thank you.